Has the sheer amount of health information out there ever felt like, well, just too much? Especially when you're worried about your kids. Maybe it's a child's upset stomach that has you Googling late at night, just trying to figure things out.
Oh, absolutely. It's a really common feeling. Trying to navigate children's health, it can definitely feel overwhelming. You just want clear, reliable answers.
Well, this deep dive is specifically for you, the learner,
Yeah.
the person who wants to really get what's going on with children's gastrointestinal health, not just, quick fixes or scary headlines. We're aiming for a thorough but hopefully manageable understanding.
Exactly. Our goal today is to really dig into a key resource, the chapter on gastrointestinal disorders in children from the Saunders NCLEX-PN review.
Mhm.
Think of this as sort of a guided tour through the key things healthcare pros focus on.
Right. We're pulling out the core knowledge, the main concepts, how to assess what might be going on, the really crucial interventions, and super importantly, how to keep kids safe when they're facing these issues. We want to make this accessible,
Yeah.
understandable.
And this chapter really highlights two priority concepts right up front: elimination and nutrition. That tells you immediately just how fundamental this area of health is for a child's overall well-being for their development.
And for those of you who really like to test your understanding, the chapter even has review questions. So consider this our deep dive into the most important stuff. Okay, let's start unpacking this, beginning with something so many parents deal with: vomiting.
Right. So when a child vomits, it might seem, well, messy but simple. But for healthcare providers, several big concerns pop up immediately. The biggest one is definitely dehydration. Little bodies can lose fluids and essential minerals, electrolytes really, really quickly.
Yeah, because they have less fluid reserve than adults, right?
Yeah.
So even a small loss is a bigger deal.
Precisely. And it's not just about losing fluids and electrolytes. Vomiting can also mess with the body's acid-base balance. It can lead to something called metabolic alkalosis. That basically means there's too much bicarbonate, making the blood too alkaline. And because kids have less buffer capacity, even small shifts can have pretty pronounced effects quickly.
Okay, that makes sense. So it's deeper than just the obvious fluid loss.
Absolutely.
Right.
Then there's the risk of aspiration, stomach contents getting into the lungs. If that happens, it can cause atelectasis, basically part of the lung collapses, which makes it hard to get enough oxygen. And that, unfortunately, can turn into pneumonia, a serious lung infection.
Wow, okay. That really clarifies why even simple vomiting needs careful attention in kids. What sort of things can actually cause a child to vomit? It feels like it could be almost anything.
You're right. The list is pretty broad. It ranges from common things like infections, viruses, bacteria, to more complex issues like increased intracranial pressure, pressure inside the head. Also exposure to toxins, food intolerances, blockages in the gut, metabolic problems, even psychological stuff can trigger it.
So if a child is vomiting, what are the key things we need to be watching for? What are the critical assessments?
Well, first, you want to be alert for signs of aspiration. The chapter doesn't list specifics, but as a caregiver, you might notice coughing or breathing trouble right after they vomit. Then, really look at the vomit itself. What color is it? What's the consistency? Is there any blood? Or bile? Bile is that greenish yellow stuff from the liver. Seeing that might suggest a blockage further down the digestive tract.
That's a really useful distinction. Blood could mean irritation up high, like you said. Bile could mean a problem lower down.
Exactly. Also, find out if there's any pain or cramping. And then, critically, assess for dehydration. Look for things like a sunken soft spot or fontanelle on a baby, skin that doesn't snap back when you gently pinch it, that's poor skin turgor, dry mouth, fewer tears when crying, and decreased peeing, which we call oliguria.
And we also need to keep in mind those potential electrolyte imbalances and metabolic alkalosis signs, even if the chapter doesn't detail them for parents.
Correct. Healthcare pros would check electrolytes with blood tests and look for clinical signs of alkalosis, like breathing changes or muscle issues. For immediate actions, though, the absolute priority is keeping the airway clear. Position the child on their side, that's so important to prevent aspiration, and monitor their vital signs, heart rate, breathing, things like that.
Makes total sense, airway first.
And keep a really close eye on the vomiting itself, how often, how much, and those characteristics we talked about: color, consistency, blood, bile. Now, here's a really key point. Notice the force of the vomiting. Is it projectile? Like really forceful? That can be a big clue for something like pyloric stenosis, and narrowing at the stomach outlet or even increased pressure inside the head. That's a crucial aha moment.
Wow, okay, so how they vomit tells you a lot.
Definitely. Track their intake and output meticulously. How much are they drinking? How much are they losing through vomit and urine? Keep checking for those dehydration signs. Monitoring electrolytes is mentioned, but that's usually done via blood tests by the healthcare team.
Okay, and what about getting fluids back into them?
Oral rehydration therapy, or ORT, is key for mild to moderate dehydration. You give it as they can tolerate it, as prescribed. Start slow, small, frequent sips. The chapter mentions things like rehydrolyte, infolite, gastrolyte, Pedialyte. These are specifically designed with the right mix of electrolytes and fluids. For more severe cases, they might need IV fluids in a hospital setting.
So those regular sports drinks aren't the best choice then. Maybe too much sugar, wrong electrolytes.
Exactly. They can sometimes even make diarrhea worse if that's also happening. Stick to the specific ORT solutions. Also, watch for other symptoms like diarrhea or belly pain. And finally, parent education is huge. Make sure parents know how to use the ORT solutions and when to call their provider signs of dehydration, bloody vomit, forceful vomiting, or bad abdominal pain.
That's a really clear guide for understanding and managing vomiting. Now let's switch to another really common GI issue, diarrhea.
Right. Acute diarrhea, the kind that starts suddenly, is a major dehydration risk, especially for kids under 5. Again, they can lose fluids so fast. Causes can include infections like viruses or bacteria, antibiotics messing with the gut bacteria balance, and parasites.
Yeah, that antibiotic diarrhea link is something many parents notice. It disrupts the normal gut flora, right?
Precisely. Now, chronic diarrhea, the kind that lasts longer, can have different causes. Things like rotavirus infection, problems absorbing nutrients like malabsorption syndromes, inflammatory bowel disease or IBD, immune issues, food intolerances, or sometimes it's just nonspecific.
And the chapter specifically flags rotavirus.
Yes, rotavirus is a really common and serious cause of gastroenteritis, especially in young kids. It's also a big issue in healthcare settings, what we call a nosocomial pathogen. It tends to hit kids hardest between 3 and 24 months. Interestingly, babies younger than 3 months often get some protection from antibodies passed from their mom during pregnancy.
That passive immunity is amazing. So when assessing a child with diarrhea, what are we looking for?
Similar to vomiting, you want to look closely at the stools, how often, what's the consistency, like watery, loose, the color, any weird odor, ask about pain or cramping, and again, look for those signs of dehydration and electrolyte imbalance.
And the chapter notes a difference in the acid-base balance compared to vomiting.
Yes, and this is a really key distinction. Vomiting can lead to metabolic alkalosis, too much base. Diarrhea often leads to metabolic acidosis, too much acid in the body. So both cause electrolyte loss, but they affect the body's pH differently.
Okay, that's a critical difference. What are the main interventions for diarrhea?
First off, monitor those stool characteristics closely: frequency, amount, consistency. If it's likely infectious, you might need enteric isolation, special precautions to stop the spread through stool. And of course, educate everyone, parents, the child, if they're old enough, about really good hand washing.
Hand washing. Seems like it always comes back to that, doesn't it?
It really does. Also, watch their skin integrity. Frequent diarrhea can really irritate the diaper area. Strict I&O monitoring, keep an eye on electrolytes, and watch for dehydration signs.
And getting fluids back in, how does that work with diarrhea?
For mild to moderate dehydration, ORT again, like Pedialyte. The chapter advises against carbonated drinks. They cause gas and things high in sugar, like straight apple juice. Those sugary drinks can sometimes pull more water into the gut and make diarrhea worse.
So again, stick to those balanced ORT solutions. What if the dehydration is severe?
They might need to be MPO nothing by mouth to rest the bowel. Fluids and electrolytes will be given through an IV. And here's a huge safety point. If IV potassium is ordered, you must make sure the child has peed recently and has good kidney function before giving it. Kidneys regulate potassium, so giving it when they aren't working right is dangerous.
That is a really crucial safety check.
Definitely. Once they're rehydrated, you gradually reintroduce a normal, age-appropriate diet. Remember, the big worries with diarrhea are dehydration, electrolyte loss, and that metabolic acidosis.
Okay, let's shift gears now to conditions present at birth, congenital anomalies. Let's discuss cleft lip and cleft palate.
Sure. Cleft lip and cleft palate are birth defects where the lip tissues or the roof of the mouth, the palate, don't fuse together completely during early pregnancy. This leaves an opening or cleft. It can be just the lip, just the palate, or both. It can be on one side or both, and it varies in size, usually pretty noticeable right at birth.
What causes that failure to fuse? Is it mainly genetic, or are there other things?
It's usually a mix of both, actually. Genetics play a part, but environmental factors during pregnancy matter too. Things like radiation exposure, certain infections like rubella, chromosome issues, or exposure to teratogens. Teratogens are just substances that can cause birth defects, like certain medications, alcohol, smoking.
And I gather the timing for surgical repair is pretty important.
Yes, definitely. The lip repair is usually done first, typically around 3 to 6 months old. Palate repair comes later, usually between 6 and 24 months. Waiting a bit allows for some natural palate growth. A key reason for doing the palate repair relatively early is to help with normal speech development as the child starts talking.
The chapter also mentions kids with cleft palate are more prone to ear infections.
That's right. They have a higher risk of otitis media middle ear infections. It's because of issues with the eustachian tube that connects the ear to the throat. If those infections aren't managed well, they can unfortunately lead to hearing loss.
Sounds like caring for these kids often involves a whole team of specialists.
Absolutely. It really takes a multidisciplinary team. You might have audiologists for hearing, orthodontists for teeth and jaw alignment, plastic surgeons for the repairs, and OTs and speech therapists for feeding help and speech development.
So when a baby's born with a cleft, what are the immediate assessment priorities?
Right away, you need to check their ability to suck, swallow safely, handle their saliva without choking, and breathe easily. Monitoring their fluid and calorie intake and their weight every day is crucial to make sure they're growing properly.
And I imagine feeding can be a real challenge.
It often is. That normal sucking action is difficult with an opening in the lip or palate. So feeding techniques usually need modifying. You might use special techniques, maybe an obturator, a device to temporarily cover the palate opening, or special nipples and feeders designed for clefts.
What are some practical feeding tips?
Holding the baby more upright helps a lot. Try to aim the formula or milk towards the side and back of the mouth, away from the cleft, to reduce aspiration risk. Give small amounts slowly and burp them really often because they tend to swallow more air. And definitely keep suction equipment, like a bulb syringe, handy at the bedside, just in case.
I see the chapter mentions the ESSR feeding method.
Yes, ESSR stands for enlarge the nipple hole, stimulate the sucking reflex, ensure they swallow, and allow for rest periods during the feed. It's a structured way to help feeding. It's also so important to support the parents emotionally, let them express their feelings, and really encourage bonding, holding the baby, using their name.
Absolutely, that parental support is key. Okay, what about after the surgery? Let's start with care after a cleft lip repair.
After lip repair, the main goal is protecting that surgery site. Sometimes lip protective devices are used. Crucially, avoid positioning the baby on the repaired side or tummy down. That puts pressure on the stitches. Back or upright is best, always making sure the airway is clear.
Keeping pressure off that lip is vital for healing.
Exactly. Keep the site clean and dry. Gently clean the suture line after feedings as ordered, often with saline. Antibiotic ointment might be prescribed. Elbow restraints, sometimes called no-nos, are usually used to stop the baby from touching the site. Monitor closely for infection, redness, swelling, drainage. And manage pain with regular analgesics and comfort measures like rocking.
Yes. Now, what about after a cleft palate repair? That seems like it would have different considerations.
It does. Feeding is restarted based on the surgeon's orders. Could be bottle, breast, cup, maybe a special syringe. Sometimes packing is put in the palate during surgery. That usually comes out after a couple of days. A really key point. Absolutely no teeth brushing while the palate heals. And avoid hard foods, toast, crackers, cookies that could hurt the site.
So a soft diet is essential then?
Yes. Pureed foods, liquids. Soft elbow restraints might still be used to keep fingers and objects out of the mouth. Remember to check skin under restraints regularly. Critically important. Avoid oral suctioning or putting anything in the mouth unless the surgeon says so. No tongue depressors, oral thermometers, straws, spoons, forks, pacifiers, certain toys. Good pain control is vital to keep them comfortable and prevent excessive crying, which strains the palate. Reinforce feeding and site care with parents, watch for infection signs, encourage holding, and get those dental and speech therapy referrals started for long-term care.
That's a really thorough look at cleft lip and palate. Okay, let's move to another set of congenital issues. Esophageal atresia and tracheoesophageal fistula, or ETEF.
Right. Esophageal atresia, or EA, means the esophagus, the food tube, didn't form completely. It ends in a blind pouch instead of reaching the stomach. Tracheoesophageal fistula, TEEF, is an abnormal connection between that esophagus and the trachea, the windpipe. They often happen together.
So with EA, food can't get to the stomach. And with TEF, fluids or air can go into the wrong places.
Exactly. Oral intake like saliva or formula can go into the lungs via the fistula, or air can fill the stomach. Babies with EAT-HF often choke, cough, and get severe abdominal distension, a swollen belly. Aspiration pneumonia and severe breathing problems can develop super fast. It needs surgery. It can be life-threatening otherwise.
Sounds incredibly serious, needing immediate attention. What are the main treatment goals?
Number one, maintain a clear airway. Number two, prevent pneumonia by stopping fluids getting into the lungs. Also, decompress the stomach and that blind pouch, provide supportive care, and then the definitive fix is surgical repair of both defects.
What are the classic signs that might make you suspect ETEF in a newborn?
You might see lots of frothy saliva, constant drooling. The chapter highlights the 3 C's: coughing, choking during feeding attempts, and cyanosis, that bluish color from lack of oxygen. Also, regurgitation or vomiting, a distended abdomen, and increased breathing difficulty, especially during or after trying to feed.
Those 3 C's, coughing, choking, cyanosis with feeding, seem like a really important warning cluster. What are the immediate interventions before surgery?
The baby will likely be in a radiant warmer, maybe get humidified oxygen. If breathing is really bad, they might need intubation and a ventilator. Strictly NPO, nothing by mouth. 4V fluids are started for hydration. Frequent gentle suctioning of the mouth and throat is essential to prevent aspiration. Position them supine, upright, head elevated at least 30 degrees. Helps drainage, reduces aspiration risk.
And what about that blind esophageal pouch? How's that managed?
You need to keep it empty of secretions, usually done with intermittent or continuous suction via a special catheter placed in the pouch. You have to watch that catheter closely, make sure it stays clear, doesn't get blocked by mucus. If they have a G-tube, gastrostomy tube in the stomach, it might be left open to drain initially. This lets air escape, reducing regurgitation into the trachea. Broad-spectrum antibiotics are usually started early because the risk of aspiration pneumonia is so high.
So pre-op is all about preventing complications and stabilizing the baby.
Okay.
What happens after the surgical repair?
Post-op, you need continuous, careful monitoring of vital signs and breathing. They'll still get IV fluids, antibiotics, maybe parenteral nutrition, IV nutrition. Strict I&O, daily weights are crucial for hydration status. Monitor pain. If there's a chest tube, ensure it's working properly. Watch the surgical site for infection.
The chapter mentions watching for anastomotic leaks.
Yes, that's a serious potential complication. It's when the surgical connection, the anastomosis between the esophagus ends, doesn't heal right and leaks. Signs include purulent, like pus-like, drainage from the chest tube, a rising temperature, or a high white blood cell count. Report those immediately. If there's a G-tube, it's usually kept draining by gravity until feedings can start and the anastomosis heals, maybe 5-7 days. Then G-tube feedings begin.
What about starting oral feeds after surgery?
Before oral feeds start and before a chest tube is pulled, they usually do an esophagram. That's an X-ray using contrast to check the esophagus connection is intact, no leaks. When starting G-tube feeds, elevate the tube above the stomach level first. Helps secretions move down and lets air escape up the tube. Initial oral feeds are tiny amounts of sterile water, then slowly progressing to small, frequent formula feeds as ordered. If there is cervical esophagostomy and opening in the neck, check that site for redness, breakdown, drainage. Keep it clean, apply ointment or a barrier as needed. Non-nutritive sucking, like a pacifier, can be helpful if they're NTO long-term, but only if they can handle their secretions. Reinforce everything with parents. Suctioning, G-tube care, feeding, skin care. Teach them signs they need to suction, signs of breathing trouble, and signs of possible esophageal narrowing later on, like poor feeding, difficulty swallowing, drooling, coughing with feeds.
That's incredibly detailed on ETEF. Let's move to reflux, GER, and GERD, very common stuff.
Right. Gastrosophageal reflux, or GER, is just the backflow of stomach contents into the esophagus. Happens because the lower esophageal sphincter, the valve muscle, relaxes when it shouldn't or isn't strong enough. It's really important to know that most infants have some GER, spitting up, pause sitting, and it's usually mild, improves by about a year old with simple measures.
So that normal baby spit up usually isn't a major worry.
Exactly. But gastroesophageal reflux disease, GERD, is when that reflux causes persistent, troublesome symptoms or complications in the esophagus, or even the respiratory system.
What kind of symptoms signal GER, not just normal GER?
Things like frequent, significant spitting up or vomiting, poor weight gain or weight loss, lots of irritability, sometimes vomiting blood, hematemesis, heartburn in older kids, and even anemia from chronic irritation.
So it's more serious if it's affecting their growth and well-being.
Mm-hmm.
What do we need to monitor in kids suspected of having GERD?
Keep a detailed record of the spitting up or vomiting, how much, what it looks like, how often.
Yeah.
Note if it happens related to feeding times or activity. Listen to their breath sounds before and after feeds for signs of aspiration. Watch for coughing, gagging, choking, or breathing difficulty after feeds. Keep suction handy, especially for babies with bad reflux. Monitor I&O and watch for dehydration. 4 fluids might be needed sometimes.
And the chapter mentions potential complications from chronic GERD.
Yes, if it's long-standing or severe, it can lead to esophagitis, inflammation of the esophagus, esophageal strictures narrowing that makes swallowing hard, repeated aspiration into the lungs, and even aspiration pneumonia.
Positioning is a big topic with reflux and safe sleep. What's the current guidance?
Okay, the primary recommendation for all infants to reduce SIDS risk is supine sleeping on their back. Always. However, in very rare specific cases where the risk from severe GERD complications like constant aspiration is judged by the doctor to significantly outweigh the SIDS risk, a different position might be ordered. If prone, tummy sleeping is ordered in those very limited situations. It must only be when the baby is awake and directly, continuously monitored by an adult. For older kids, over a year, elevating the head of the bed might help reduce reflux symptoms.
Okay, so back to sleep is still the main, vital rule for safety. What about diet changes for GERD?
Small, frequent feeds might help. Sometimes a pre-digested formula, easier to digest, is tried. For severe cases with poor growth, they might need NG tube feeding. For infants, thickening formula with a bit of rice cereal is sometimes recommended, but follow doctor's orders exactly, and you'll need a cross-cut nipple for the thicker feed. Breastfeeding can usually continue. Maybe feed more often, or express milk and thicken it under guidance. Burp frequently during feeds, handle them gently afterwards. Watch closely for coughing or aspiration signs during feeding. For toddlers, try solids before liquids at meals.
Are there specific foods parents should try to avoid giving older kids with GERD?
Yes, it can help to avoid fatty foods, chocolate, tomato products, fizzy drinks, fruit juices, citrus, spicy foods. These can aggravate reflux in some people. Also, avoid rough play right after eating and try not to feed them right before bedtime.
And medications can help manage GERD symptoms too, right?
Definitely. Antacids give quick, temporary relief. Medications called proton pump inhibitors, PPIs, and H2 antagonists are often prescribed to reduce stomach acid production, which lessens the irritation.
All right, let's shift to another condition affecting food passage in infants. Hypertrophic pyloric stenosis.
Hypertrophic pyloric stenosis happens early in infancy. The muscle of the pylorus, that valve between the stomach and the small intestine, gets abnormally thick and enlarged. We call that hypertrophy. This thickening narrows the pyloric canal, making it really hard for food to get out of the stomach.
And this usually shows up pretty early, doesn't it?
Yes, symptoms typically start between 2 and 6 weeks old. The classic sign is projectile vomiting. Really forceful vomiting after feeding, sometimes shooting quite far. Because the stomach can't empty, it leads to dehydration, metabolic alkalosis, and failure to thrive because they can't keep food down.
What are other key signs beside that projectile vomiting?
The vomiting often starts milder, then gets progressively more forceful. It's almost always right after feeding. The vomit is just stomach contents, milk, formula, maybe some mucus or a little blood from irritation, and this is a key clue, it usually doesn't contain bile. Babies with this are often super hungry and irritable, especially right after vomiting. Sometimes you can even see waves moving across their upper belly left to right as the stomach tries hard to push food through. That's peristalsis. And sometimes a doctor can feel a small, firm, olive-shaped lump in the upper abdomen, just right of the belly button. And of course, you'll see signs of dehydration, malnutrition, electrolyte problems, and that metabolic alkalosis as it progresses.
So no bile in the vomit and that palpable olive are pretty significant clues. What are the initial nursing steps if this is suspected?
Strict I&O monitoring is crucial. Keep detailed logs of vomiting time, amount, type, and their stools. Get daily weights to track hydration. Continuously watch for those clinical signs of dehydration and electrolyte imbalance. The definitive treatment is usually surgery, a pyloromyotomy, so you'll help prepare the child and parents for that if it's ordered.
Can you briefly explain what that pyloromyotomy surgery involves?
Sure. The surgeon makes a cut through the thickened outer muscle layer of the pylorus down to the inner lining. This releases the tightness, widens the channel so food can pass through easily. It can often be done laparoscopically now with small incisions.
What's the main focus of nursing care before the surgery?
Pre-op, the focus is correcting dehydration and electrolyte problems. Monitor hydration closely, daily weights, I&O, urine-specific gravity. Give IV fluids with electrolytes as ordered. Keep the baby strictly NPO. Monitor stools. An NG tube is often placed to decompress the stomach, keep it empty, make sure that NG tube stays working.
And after the surgery, what does recovery look like?
Post-op, keep monitoring INO. Small, frequent feeds will be started as prescribed, usually a few hours after surgery. They'll gradually increase the amount and time between feeds back to a normal schedule. Feed slowly, burp very frequently. Handle the baby gently after feeds to reduce vomiting risk. Monitor for belly distension. Watch the surgical wound for infection signs, redness, swelling, drainage. Reinforce wound care and feeding instructions with parents before discharge.
Okay, let's switch focus now to food intolerances, specifically lactose intolerance. What is that?
Lactose intolerance is really common, is difficulty digesting lactose, the natural sugar in milk and dairy. It happens because the body doesn't make enough lactase, the enzyme produced in the small intestine that breaks down lactose so it can be absorbed.
So if there's not enough lactase, the lactose causes problems moving through the gut. What kind of problems?
Symptoms usually show up after having lactose-containing foods or drinks. Things like abdominal bloating or distension, crampy pain, sometimes like colic, diarrhea, and excessive gas or flatulence.
How is it usually managed in kids?
Main approach is either reducing or cutting out lactose-containing dairy or using enzyme replacements. Parents can get over-the-counter lactase enzyme tablets or drops to take right before eating dairy. Helps pre-digest the lactose. For babies, soy-based formulas are often a good alternative to cow's milk formula or even breast milk if mom's dairy intake is affecting the baby. Older kids might tolerate small amounts of dairy, maybe with other foods. Some products like heart cheeses, cottage cheese, yogurt with live cultures often have less lactose and might be okay. Sometimes trying small amounts regularly can help the gut bacteria adapt. It's also really important to teach parents about hidden lactose in processed foods.
Are there nutritional worries if dairy is cut way back?
Yes, dairy is a major source of calcium and vitamin D, vital for bones, especially in growing kids. So if dairy intake is low, parents need to know about the risk of deficiency and discuss supplements or other dietary sources to make sure the child gets enough.
Another dietary issue covered is celiac disease. What's that?
Celiac disease, also called gluten enteropathy or SPRU, is an autoimmune disorder. It's triggered by an intolerance to gluten. Gluten is a protein found in wheat, barley, rye, and sometimes oats due to cross-contamination.
And what happens in the intestine when someone with celiac eats gluten?
Their immune system reacts and attacks the lining of the small intestine. Specifically, it damages the villi, those tiny finger-like things that absorb nutrients. When the villi get flattened or damaged, the body can't absorb nutrients properly. That leads to malabsorption.
When do celiac symptoms usually start showing up in kids?
It varies, but often between ages 1 and 5. Symptoms frequently start about 3 to 6 months after gluten is first introduced into their diet.
And the main treatment is a strict gluten-free diet, right? Why is lifelong avoidance so crucial?
Absolutely. Strict lifelong avoidance is essential. Continued gluten exposure keeps damaging the intestine, causing ongoing malabsorption. Over time, this increases the risk of serious problems, including certain types of lymphoma and other GI cancers. The gluten-free diet lets the gut heal, the villi recover, improving absorption and reducing those long-term risks.
What are some common signs that might make you suspect celiac disease in a child?
Symptoms can vary. Some have a sudden onset, others more gradual. Common things include chronic diarrhea, often watery, pale, and really foul-smelling. Also, steatorrhea, fatty stools that are bulky, pale, hard to flush. Loss of appetite, belly pain and bloating. Muscle wasting, especially buttocks, limbs. Vomiting, anemia, and irritability. The chapter also briefly mentions celiac crisis, a severe, acute flare-up needing immediate medical help.
How is celiac diagnosed and managed?
Diagnosis usually involves blood tests for specific antibodies, then often an endoscopy with biopsies of the small intestine to look for villi damage. Management is that strict, lifelong, gluten-free diet. No wheat, rye, barley, or regular oats. Substitute with corn, rice, millet. Because of malabsorption, they often need mineral and vitamin supplements, iron, folic acid, vitamins A, D, E, K. Educating parents and the child about the diet is vital. Reading labels carefully is key. The chapter likely has lists of allowed forbidden foods, teach them how to prevent celiac crisis, point them towards support groups like the Celiac-SPRU Association.
Let's move to a more acute abdominal issue, appendicitis.
Appendicitis is inflammation of the appendix, that little figure-like pouch off the large intestine. It's serious because an inflamed appendix can rupture or perforate really quickly, sometimes within hours. A rupture leads to peritonitis infection of the abdominal lining, which can cause sepsis, shock, even death. So standard treatment is surgical removal and appendectomy, ideally before it ruptures.
That quick rupture risk really stresses the need for fast diagnosis and treatment. What are the classic signs of appendicitis in a child?
The pain often follows a pattern. Starts dull, crampy around the belly button, then moves down to the lower right abdomen over hours. It's often most intense at McBurney's point. If the pain suddenly spreads out, that might mean rupture and peritonitis. You might see rebound tenderness. Pain is worse when you quickly let go after pressing an abdominal rigidity, like the muscles are stiff. Blood tests often show a high white blood cell count. Kids often lie still, maybe side-lying with knees bent up guarding. They might have trouble walking or right hip pain. Low-grade fever is common. Loss of appetite, nausea, vomiting usually start after the pain begins. Some kids have diarrhea.
And the chapter flags a concerning sign about a change in pain.
Yes, this is really important. If the child's pain suddenly gets better, that can actually happen if the appendix ruptures. But that relief is usually temporary, followed quickly by worse, more spread out pain and guarding signs of peritonitis. That's an emergency. If peritonitis develops, they often get a higher fever, worsening belly distension, fast heart rate, fast breathing, look pale, get chills, become restless or irritable.
Treatment is appendectomy. What's key in nursing care before the surgery?
Pre-op, strictly NPO. 4V fluids for hydration and electrolytes. Monitor constantly for signs of rupture or peritonitis. Pain meds might be held initially so they don't mask signs of perforation. Antibiotics are often started. Monitor bowel sounds. Position for comfort, right side lying or low semi-Fowlers, head slightly up, maybe knees bent. Ice packs to the abdomen might be ordered. Crucially, never apply heat or give laxatives or enemas if appendicitis is suspected can increase rupture risk.
And what about nursing care after the appendectomy?
Post-op monitor temperature for infection. Stay NPO until bowel function returns. Listen for bowel sounds. Then advanced diet slowly clear liquids to regular, as tolerated and ordered. Watch the incision for infection redness, swelling, drainage, pain. If it ruptured, there might be a Penrose drain. Monitor its drainage. Position right side lying or low semi-Fowlers with legs slightly bent to help drainage and comfort. Change dressings as ordered. Record drainage. Wound irrigations might be needed. If there's an NG tube, keep it on suction until bowel activity returns. Give antibiotics and pain meds as prescribed.
Okay, let's discuss Hirschsprung's disease, a congenital issue with the large intestine.
Hirschsprung's disease, also called congenital aganglionosis or aganglionic megacolon, is a birth defect. It's characterized by the absence of specific nerve cells, called ganglion cells, in the wall of the rectum and sometimes a variable length of the colon above it. These nerve cells control the muscle contractions, peristalsis, that move stool along. Without them, that section of bowel can't relax or push stool forward properly, causing a functional blockage.
So it's a nerve problem in the bowel wall affecting movement. Can it run in families?
Yes, it can be inherited sometimes. It's also sometimes linked with Down syndrome or urinary tract abnormalities. Diagnosis is confirmed by a rectal biopsy, looking for the absence of those ganglion cells under a microscope.
What are the major potential complications?
The most serious is enterocolitis inflammation of the colon. Signs include fever, severe weakness or exhaustion, prostration, GI bleeding, and explosive watery diarrhea. It's very dangerous.
How is Hirschsprung's usually treated?
Depends on severity. Mild cases might be managed with stool softeners and regular rectal irrigations, but most cases, especially more severe ones, need surgery. Often it's a two-step process. First, usually in newborns, a temporary colostomy is created. This diverts stool out through an opening in the abdomen, relieving the obstruction and letting the healthy bowel recover. Later, a pull-through procedure is done. They remove the affected bowel section lacking nerves and connect the healthy bowel down to the anus, often closing the colostomy then too.
What are early signs in newborns that might suggest Hirschsprung's?
Key signs include failing to pass meconium, that first dark stool, within 24 or 48 hours of birth. Also, refusing to suck or feed well, a swollen abdomen, distension, and possibly bile-stained vomit.
What about in older infants or children?
You might see failure to gain weight or grow properly, ongoing abdominal distension, vomiting, chronic constipation, maybe alternating with diarrhea, overflow, and stools that look ribbon-like and smell very foul.
What does the non-surgical medical management involve?
It focuses on helping bowel movements, often a low-fiber, high-calorie, high-protein diet, maybe 5E nutrition if needed. Stool softeners are usually prescribed. Daily rectal irrigations with normal saline might be done as ordered to help clear stool and prevent obstruction.
And what about managing it surgically, pre-op and post-op care?
Pre-op. Monitor bowel function, give bowel prep if ordered. Strictly NPO. Monitor hydration, give IV fluids. Antibiotics, maybe as irrigations to reduce bowel bacteria. Strict I&O, daily weights. Measure abdominal girth regularly. Crucially, avoid rectal temperatures, risk of injury. Monitor for breathing problems due to abdominal distension.
And post-op care after surgery, like the colostomy or pull-through?
Post-op, monitor vital signs. Again, no rectal temps. Measure abdominal girth daily. Check the surgical site for infection signs. If there's a colostomy, check the stoma should be red, moist. Watch for bleeding or skin breakdown. If pull-through, check the anal area for stool passage, redness, discharge. Stay NTO until bowel sounds return and they pass gas, usually 48-72 hours. NG tube on suction until then. 5E fluids until oral intake okay, then advance diet slowly. Monitor for dehydration or fluid overload. Strict I&O, daily weights. Manage pain. Thorough parent education on colostomostoma care if needed, skin care, diet, fluids. If anal dilations are prescribed post-pull-through, teach parents the exact procedure, carefully use only provided dilators, lubricant, insert gently 1 to 2 centimeter.
Let's move on to intussusception, where the bowel telescopes into itself.
Right. Intussusception is when one part of the intestine folds into the section next to it, like collapsing a telescope. The chapter likely has a picture showing this. This telescoping blocks the passage of intestinal contents and can cut off the blood supply to that part of the bowel.
Sounds incredibly painful. What are the typical signs?
It is very painful. A classic sign is sudden, severe, colicky belly pain that comes in waves. The child often screams and pulls their knees to their chest during these episodes. Vomiting is common, starting with stomach contents, then maybe bile-stained, eventually even looking like feces. A very characteristic sign is passing current jelly stools, stools mixed with blood and mucus, giving them that look. On exam, bowel sounds might be decreased or increased. The belly might be tender, distended. Sometimes the doctor can feel a sausage-shaped mass, usually in the upper right abdomen.
Those current jelly stools seem like a very specific red flag. What are the immediate nursing concerns and actions?
The biggest immediate worries are bowel perforation and shock. So continuous monitoring for signs like fever, fast heart rate, changes in consciousness or blood pressure, or respiratory distress is crucial. Report any of those immediately. Initial steps might include antibiotics, IV fluids, and maybe NG tube decompression. Also, watch closely for the passage of a normal brown stool that can mean it fixed itself, called self-reduction. If there's no perforation or shock, they might try hydrostatic reduction using air or fluid pressure via the rectum to gently push the bowel back into place.
What's the care like after that hydrostatic reduction?
After reduction, keep monitoring for return of normal bowel sounds, passage of the contrast material if used, and normal stool. Start clear liquids and advance the diet gradually as ordered and tolerated. If reduction fails or surgery is needed, post-op care is similar to other abdominal surgeries.
Okay, let's look at abdominal wall defects present at birth. Omphalocele and gastroschisis.
Right, both involve abdominal organs protruding outside the belly near the navel, but they're different. Omphalocele happens through the umbilical ring itself. The organ's bowel, maybe liver or stomach, are covered by a thin, translucent sac made of peritoneum and amnion.
So with omphalocele, the organs are outside but still in a protective sac. How is gastroschisis different?
Gastroschisis is a defect next to the umbilical ring, usually to the right. And the key difference, there's no membrane covering the exposed organs. The bowel is just out there.
Wow, having the bowel exposed like that must pose big challenges for protection and infection.
It definitely does. Right after birth, the exposed bowel in gastroschisis is loosely covered with sterile saline-soaked pads to keep it moist. The whole abdomen bowel is then loosely put in a sterile plastic draper bowel bag. You don't wrap it tightly, risk of pressure damage if the bowel swells. Pre-op care for both is about protecting the organs from drying, injury, infection, and maintaining body temp. Keep the sac or bowel moist with saline dressings, cover with plastic to reduce fluid heat loss. Monitor vitals, especially temp, frequently. Keep MPO, give IV fluids, watch for infection. Handle very carefully to avoid rupture or injury. For gastroschisis, since there's no sac, surgery is usually done within hours of birth. Post-op care involves pain control, infection prevention, fluid electrolyte balance, nutrition, often IV nutrition initially. Gastroschisis babies often have prolonged ileus bowel, doesn't work right away, so they might need ventilation and long-term IV nutrition. Otherwise, post-op care is similar.
Let's touch on other hernias common in kids: umbilical, inguinal, and hydroceles.
Okay, a hernia is just tissue poking through a weak spot. Umbilical hernias at the belly button and inguinal hernias in the groin are common in kids. A hydrocele is different. It's fluid buildup in the scrotal sac.
What do these look like, typically?
An umbilical hernia is usually a soft bulge around the navel, often reducible. You can gently push it back in. An inguinal hernia is a bulge in the groin, usually painless, reducible, might pop out more with crying or coughing, disappear at rest. Now, an incarcerated hernia is serious. That's when the bowel gets trapped, blood supply is cut off. It's a surgical emergency. Signs include irritability, tenderness at the site, poor appetite, belly distension, trouble pooping. Can lead to obstruction, gangrene. Hydroceles, a non-communicating one, is trapped fluid, usually resolves by age 1. A communicating hydrocele connects to the abdomen, associated with a hernia. The bulge changes size with straining rest.
So for hernias, surgery is often needed, especially if there's incarceration risk. What's post-op care like?
After hernia repair, monitor vitals, watch the wound for infection, redness, drainage, monitor hydration, advanced diet as tolerated, give pain meds.
Is it different after a hydrocele repair?
After hydrocele repair, ice bags to the scrotum help with swelling pain. Scrotal support might be used. Tell parents no tub baths until healed. Avoid strenuous activity for a while.
Let's talk about bowel elimination issues. Constipation and encopresis.
Constipation is basically infrequent or difficult passage of dry, hard stools. Encopresis is constipation with fecal incontinence, soiling clothes, often involuntarily. Usually encopresis happens because chronic constipation leads to fecal impaction and an enlarged, less sensitive rectum. Liquid stool then leaks around the hard mass. This assumes no underlying nerve or anatomy problem.
So the constipation often leads to the soiling.
Often, yes. The stretched rectum loses its normal sensation. What signs might you see with constipation? Maybe belly pain, cramping, usually no major swelling. You might feel hard stool masses in the abdomen. Bowel sounds normal or decreased, maybe malaise, headache, poor appetite, nausea, vomiting if severe.
And with encopresis?
Obvious soiling of clothes, maybe scratching, rubbing the anal area, fecal odor, sometimes social withdrawal due to embarrassment.
How are constipation and encopresis managed?
Diet is key. High fiber, high fluids. The chapter probably lists good fiber sources. Severe encopresis might need intensive treatment for 3 to 6 months. Sometimes decreasing sugar and milk intake helps. Enemas might be used initially to clear impaction, but monitor electrolytes carefully with repeated enemas, risk of high sodium phosphate. Stool softeners or laxatives are often prescribed regularly. Establishing regular toilet time is vital. Sit on the toilet 5-10 mins, 20-30 mins after breakfast and dinner to use the body's natural reflex.
Okay, let's discuss irritable bowel syndrome, or IBS, in children.
IBS in kids is a functional disorder, real symptoms, but no identifiable structural or biochemical cause. Thought to involve increased gut sensitivity and motility, leading to spasms and pain. Diagnosis is often by ruling out other conditions. It's often self-limiting, comes and goes, no cure. Stress or emotions might play a role for some.
What are typical IBS symptoms in kids?
Often diffuse belly pain, not clearly linked to meals or activity. Alternating constipation and diarrhea. Maybe undigested food or mucus in the stool.
How is IBS managed?
Mostly symptom relief and improving quality of life. Reassurance and education are important. Explain it comes and goes. Sometimes anticholinergic meds are used for spasms pain. Antidepressants might be considered in severe cases, especially with psychological factors, under doctor's guidance. Encourage a healthy, balanced, moderate fiber, low-fat diet. Promote normal activities, exercise, school. Offer psychosocial resources if stress anxiety seem involved.
Now let's talk about imperforate anus, a congenital anomaly.
Imperforate anus means the anus didn't form properly during development. There's a range. Might just be a membrane covering the opening, or the anus could be completely absent with the rectum ending blindly higher up. Or the rectum might connect abnormally, a fistula to the perineum, urethra, bladder, or vagina.
So it varies quite a bit. What are the key diagnostic signs in a newborn?
Key findings include failure to pass meconium soon after birth, no visible anus or a very narrow one, an obvious membrane over the anal area, or an external fistula opening on the perineum. Pre-op, it's crucial to watch for stool in the urine or vagina indicates a fistula. Report immediately. Give IV fluids as ordered. Prepare child parents for surgery, possibly including a temporary colostomy.
And post-op care after surgical correction.
Post-op, monitor the surgical site for infection. Preferred positioning is often side-lying prone with hips up, or supine with the legs suspended at 90 degrees reduces pressure swelling. Keep the anal site clean, dry, watch for redness, swelling, drainage. If they have a colostomy, provide standard care stoma, initially red swollen. Usually MPO with NG tube until gut motility returns, 4V fluids until oral feed's okay. If anal dilations are prescribed, reinforce the procedure with parents. Use only provided dilators, use lubricant, insert gently 1 to 2 centimeters only.
Shifting gears now to hepatitis liver inflammation in infants and children.
Right. Hepatitis is liver inflammation. Can be acute, sudden, short, or chronic, long-lasting, caused by viruses, medication reactions, other diseases. The chapter points to other sections for more detail.
It covers different viral types. Let's start with hepatitis A, HAV.
HAV is most common in preschool school-age kids under 15. Many kids have no symptoms but can still spread it. Some have mild nausea, vomiting, diarrhea.
What about hepatitis B, HBV? How do kids usually get it?
Most HBV in kids is acquired perinatally around birth from an infected mother, can cross placenta late in pregnancy or during birth via fluid blood ingestion or breastfeeding, as per scrap nipples. Severity varies no disease to severe, fulminant, or chronic active hepatitis. Older kids' teens' risk factors include hemophilia transfusions, drug abuse, institutionalization, living in endemic areas, sexual activity. Importantly, HBV in infancy can lead to a chronic carrier state, raising risk of cirrhosis or liver cancer later in life.
In hepatitis C, HC, how is that transmitted?
HCV is mainly parenteral contact with infected blood-body fluids, often perinatal transmission from mother to baby. In older kids, sharing needles. Many are asymptomatic long-term, but it often becomes chronic and cause cirrhosis liver cancer.
The chapter mentions Hep D and E too.
Hepatitis D only happens if you already have HPV. Tends to be more severe than HPV alone, higher cirrhosis risk, higher risk in hemophilia IV drug users if they have HPV. Hepatitis E is uncommon in U.S. kids. Doesn't become chronic, no chronic liver disease carrier state.
What are the typical phases and symptoms of viral hepatitis in kids?
Usually 2 phases. Prodromal anacteric phase, 5 to 7 days. No jaundice yet. Symptoms like poor appetite, feeling unwell, fatigue, maybe fever, SB teens, nausea, vomiting, upper belly pain, sometimes joint pain rash, SB HBV. Liver might enlarge. Then the acteric phase, jaundice appears, yellow skin, eyes, etc. Dark urine, pale stools, itchy skin, pruritus. Diagnosis involves specific blood tests.
Prevention is key. What are the main preventive measures?
Immunoglobulin gives passive immunity for HAV, pre-exposure, and HBV, post-exposure, like needle stick, or for babies of infected moms. Vaccines for Hep A and B are crucial parts of childhood immunizations, and always, proper hand washing and standard precautions are essential.
What are key nursing interventions for a child with hepatitis?
Meticulous hand washing by everyone, hospitalization if they have clotting problems or severe fulminant hepatitis. Use standard enteric precautions in hospital, enteric for HAV for 1 week after jaundice starts. Discourage sharing toys. Reinforce hand washing. Disinfect diaper change areas. Bleach solution. Ensure rest. Low-fat, balanced diet. Inform parents HAV usually isn't infectious 1 week after jaundice starts. Can return to school if well. Warn jaundice might worsen before improving. Critically, caution parents about giving any meds without checking with the doctor as the liver is compromised. Educate on signs of worsening. Changes in alertness, bleeding, fluid retention.
Okay, moving to a very serious topic, ingestion of poisons.
Right. Priority actions. Assess the child. ABCs. Intervene. CPR if needed. Terminate exposure. Empty mouth. Flesh skin. Identify poison. Questioning. Containers. Prevent absorption. Document everything. What happened. Assessment, poison, treatment response. Remember, treat the child first, stabilize them, then focus on the poison.
The chapter details specific poisoning, starting with lead.
Lead poisoning is too much lead in the blood. Exposure via contaminated food, air, water, dust, soil. Ingestion, inhalation via hand-to-mouth, paint chips, pottery, also mother to fetus, affects blood cells, bones, teeth, organs, but the central nervous system brain is most serious. Screening recommended. High-risk kids at 1 to 2 years, unscreened 3 to 6. Targeted screening for low risk if factors present. Blood lead level test is key. Erythrocyte protoporphyrin, EP test, indicates related anemia. Treatment is chelation therapy meds that bind lead for excretion via kidneys. It lowers lead levels but might not reverse existing neurological damage. Meds include calcium disodium edetate, Suxamer, oral, British anti-leucite, BAL, sometimes with edetate, BAL contraindications, peanut allergy, G6PD deficiency, don't give with iron, monitor kidney, liver, blood systems closely during chelation, ensure good urine output before starting, monitor output pH during after, keep hydrated, watch for kidney toxicity, follow-up lead levels needed, educate parents on hazards, safety, meds, follow-up, ensure safe home environment post-discharge.
Next, acetaminophen poisoning, very common.
Yes, seriousness depends on amount ingested and time to treatment. Toxic dose is around 150 milligkilograms or more. Stages. First, 2 to 4 agers, malaise, nausea, vomiting, sweating, pale, weak. Latent period, 24-36 agers, seems better, but liver damage starts. Hepatic stage, up to 7 days, permanent damage possible. RUQ, pain, jaundice, confusion, stupor, abnormal liver tests, clotting. Antidote is N-acetylcysteine, NAC, often diluted due to bad odor, given as loading then maintenance doses, oral or IV. If unconscious, gastric lavage with activated charcoal might be done, but if charcoal used, don't give NAC simultaneously, charcoal inactivates it.
How about aspirin as acetylsalicylic acid poisoning?
Still happens. Can be acute, single large dose, 300-500 milligram plus is severe, or chronic, smaller doses over days, 100 milligauge a day for 2+ days, can be more serious. Symptoms affect many systems. GI, nausea, vomiting, thirst. CNS, fast, deep breathing, confusion, ringing ears, seizures, coma, respiratory circulatory collapse, renal, low urine output. Hematopoietic, bleeding. Metabolic, sweating, fever, electrolyte lows, dehydration, low blood sugar. Interventions: activated charcoal, maybe emesis cathartics, 5E fluids, sodium bicarbonate for acidosis. Other support: cooling, anticonvulsants, vitamin K for bleeding, oxygen, dialysis if severe unresponsive.
And corrosive substances, household cleaners, bleach.
Yes, cleaners, detergents, bleach, paint thinners, batteries, liquids, often worse than granules. Ingestion causes severe burning, mouth, throat, stomach, swelling of membranes, vomiting, drooling, trouble clearing secretions. Intervention: dilute with small amount of water milk as prescribed, usually 4 ounces. Do not induce vomiting, redamages tissues. Do not neutralize, causes heat burns. Crucial parent education. Call poison control immediately before doing anything. Post the number everywhere.
Finally, the chapter covers intestinal parasites, giardiasis, and pinworms.
Yes, giardiasis is from a protozoa common in crowded places like daycare. Symptoms: diarrhea, vomiting, poor appetite growth, cramps, intermittent loose stools, constipation, fatty stools, steatorrhea. Diagnosed via multiple stool samples, treated with meds like metronidazole, tinidazole, etc. Meticulous hand washing is key. Educate family caregivers on sanitation. Pinworms and orobiasis are super common, easily spread in crowds. Main symptom: intense perianal itching, especially at night. Causes irritability, poor sleep, sometimes bedwetting. Diagnosis: sometimes visual inspection at night. Flashlight, most common. Tape on anus first thing in morning. Check for eggs under microscope. Meds like mebendazole, pyrantel pamoate, albendazole, not usually under 2. Repeat dose in 2 weeks. Treat the whole family. Emphasize hand washing all bedding, clothes in hot water.
Okay, the chapter wraps up with practice questions, numbers 3 out of 11 to 323, and gives rationales, which is great for reinforcing learning. It also explicitly answers that critical thinking box question on page 403 about a child suddenly vomiting. The answer highlights priorities: patent airway, positioning upright or side, suction ready, assessing vomit character amount force, linking projectile to pyloric, stenosis, ICP, and monitoring I and O dehydration. Finally, it lists the references used.
Yeah, those questions in the critical thinking part are really valuable for you, the learner, to check your understanding and see how to apply this information.
Well, that covers our deep dive into the gastrointestinal disorders in children chapter from the Saunders NCLEX-PN review. We've hit a lot of common stuff like vomiting and diarrhea, congenital issues, infections, poisonings, parasites.
We really aim to pull out the most critical knowledge, the core nursing concepts, assessments, key procedures, safety protocols, priority actions, everything healthcare pros need to know for kids with these GI issues.
And it's so important for you, the learner, to remember. While this was a comprehensive overview based on the chapter, every condition is unique. Always consult more resources, like the Saunders text itself, and especially qualified healthcare professionals for specific situations or deeper understanding.
Hopefully this deep dive gave you a solid foundation in pediatric GI health from this review material. So maybe a final thought for you to mull over. Considering everything we discussed, think about how profoundly a child's gut health impacts their overall growth, development, and just their day-to-day well-being. What are 1 or 2 key takeaways that really stick with you about caring for these kids?
That's a great point for reflection. And with that, we can confirm we've covered the entire provided chapter from Saunders Comprehensive Review for the NCLEX-PN Examination, 7th edition, hitting all the key concepts in pediatric gastrointestinal disorders.